Welcome to Mayo Medical Laboratories Hot Topics. These presentations provide short discussion of current topics and may be helpful to you in your practice. Our speaker for this program is Dr. James Stubbs, an assistant professor of laboratory medicine and pathology, as well as chair of the Division of Transfusion Medicine at Mayo Clinic in Rochester, Minnesota. Dr. Stubbs provides a review of the work done at Mayo Clinic to improve the process of preparing for surgery and potentially transfusion. Dr. Stubbs, thank you for presenting with us today.
Thank you for that kind introduction. I have nothing to disclose. Pre-transfusion testing is an essential set of procedures that are critical to the achievement of safe and effective outcomes of transfusion therapy. Central to this testing are the ABO group, RH type, and the antibody screen procedures performed on a blood sample obtained from the potential transfusion recipient. The purpose of the antibody screen procedure is to detect the presence of clinically significant unexpected antibodies in the potential transfusion recipient's blood that are directed against red blood cell antigens. If the antibody screen procedure yields positive results, then more extensive immunohematology studies are required to specifically identify the anti-red blood cell antibodies in the blood sample. If specific clinically significant red cell alloantibodies are identified, then donor units of red blood cells documented to lack the corresponding red blood cell antigens must be selected for the patient's transfusions. Depending on the specificity of the red blood cell antibodies identified, the process of finding units lacking the corresponding antigen or antigens can take minutes, hours, or even days. The sample that is used to perform pre-transfusion testing must meet predefined strict standards. If the potential recipient has been either pregnant or received a transfusion within the previous 3 months, that is, the recipient has evidence of recent alloimmune exposure to another person's blood, then the sample used for pre-transfusion testing must be collected within 3 days of the anticipated transfusion. If the potential recipient has not been either pregnant or received a transfusion within the previous 3 months, then the sample used for pre-transfusion testing can be collected further in advance of the anticipated transfusion. In Rochester, Minnesota, there is a transfusion medicine policy for patients who are scheduled for surgery. If the patient scheduled for surgery has not been either pregnant or received a transfusion within the previous 3 months, they are candidates for the collection of a sample which is called an early candidate pre-surgical sample, which is commonly referred to here as the PSS. An early candidate pre-surgical sample for pre-transfusion testing can be collected up to 56 days prior to the date of the scheduled surgical procedure. To activate the PSS process, a provider, within 56 days of scheduled surgery, at the time of test ordering, answers the following question: has the patient been pregnant or transfused within the past 3 months? If the provider answers no, the surgical patient is eligible for collection of the early candidate pre-surgical sample. If the provider answers yes, the surgical patient is not eligible for collection of the early candidate pre-surgical sample, and he or she is scheduled for collection of a pre-surgical pre-transfusion sample within 3 days of the date of the scheduled surgical procedure. The PSS can be used for pre-transfusion testing until 3 days after the issue and transfusion of any blood products, or a maximum of 59 days from collection, whichever comes first. At 59 days, the sample expires and can no longer be used for pre-transfusion testing, regardless of whether the patient received a transfusion or not. With regard to the results of pre-transfusion testing performed on the early candidate pre-surgical sample, if the antibody screen procedure yields negative results, then the surgical patient is eligible to receive red blood cell components identified as compatible, ABO and RH, through the use of an electronic computer-based cross-match. That is, a validated computer process is used to select the appropriate red blood cell components for transfusion of the patient. If the antibody screen procedure is positive and a clinically significant red blood cell antibody or antibodies are detected, or if the patient has a history of having a clinically significant red cell antibody or antibodies, regardless of whether it or they are currently detectable, The PSS is frozen for up to 56 days for use in a full anaglobulin phase serologic cross-match procedure to identify compatible red blood cell units for potential transfusion of the surgical patient. When a patient with an early candidate pre-surgical sample returns to our facility for admission to undergo his or her surgical procedure, the admission process includes verification of the patient's pregnancy or transfusion history, and this is documented in the medical record. If there are no changes in the pregnancy or transfusion history, the patient is ready to go from a transfusion perspective, and the PSS is the appropriate pre-transfusion sample. If the patient has had a status change, that is, either pregnant or transfused since the time of the PSS sample collection, a report automatically prints in transfusion medicine. The PSS is inactivated, and a new order for the collection of a current pre-transfusion sample is generated. The expected benefits of the early candidate pre-surgical sample process include reduced pre-transfusion testing related delays in scheduled surgical procedures because challenging clinically significant red blood cell antibody identification problems are resolved well in advance of surgery, which allows time for identification of compatible red blood cell units for transfusion. The process should also result in increased patient satisfaction because many patients will not have to report to phlebotomy in the time period just prior to surgery to have pre-surgical pre-transfusion specimen collections. To assess the success of the pre-surgical pre-transfusion testing process at our facility, we surveyed performance between the dates of October 2009 and October 2010. The survey revealed disappointing results, with 17% of pre-surgical patients who required pre-transfusion testing in advance of their scheduled surgical procedure not having their blood group and type and antibody screen procedures completed by the day of surgery. The consequences of the failure to complete pre-transfusion testing by the day of surgery include the possibility that the scheduled procedure will be delayed until the testing is completed, or, even worse, the patient proceeds to surgery and the procedure is started prior to completion of pre-transfusion testing, which sets up the possibility that transfusions might be needed before test completion, and emergent type transfusion decisions are then necessary in an elective surgical setting, which is an unacceptable scenario from a patient safety perspective. Pictured on this slide is a graph showing the percent completion of blood type and antibody screen procedures prior to surgery for the years 2007 to 2010 at our institution. The goal for completion of these procedures was 95%. As you can see, we fell disappointingly short of the goal the majority of the time. Following a successful campaign to make the powers that be aware of the potential patient safety issues related to the failure to complete pre-surgical pre-transfusion testing in a significant percentage of patients at our institution, resources were allocated to assemble a multidisciplinary process improvement team to address the problem in 2011. The process improvement team was instructed to assess the current surgical patient transfusion readiness process and identify gaps and improvement opportunities. Once the process gaps and improvement opportunities had been identified, the team was charged with designing and implementing a standard surgical patient transfusion readiness process to be used by all surgical practices, and that the standard process ensures that a pre-transfusion specimen is collected and tested prior to the morning of surgery for patients scheduled for elective surgery, and that there will be no increase in transfusion-related events. The multidisciplinary process improvement team had a surgeon, Dr. Frank Sima, as its leader and champion. The remainder of the team consisted of members from the areas listed on this slide who had the expertise to evaluate the entire surgical patient transfusion readiness process from the initial consultation visit on through to the completion of the surgical procedure. The process improvement team utilized the define, measure, analyze, improve, and control DMAIC, approach to the project. In the define phase, a project charter was developed to document the project champion and the institutional project sponsor, also describe the scope of the project, and identify the key stakeholders involved in surgical patient transfusion readiness. In the measure phase, baseline data was collected to characterize the current states of surgical patient transfusion readiness processes. Specifically, the type and screen completion rate prior to surgery, the status of PSS ordering systems, and the standard surgical blood order schedule, SSBO, were evaluated. In addition to the suboptimal type and screen completion rate prior to surgery, the process measures resulted in the identification of several problem areas during the analyze phase of the process. These included multiple surgical patient pre-transfusion ordering methods were utilized by the various surgical specialties. The instructions given to surgical patients regarding the collection of their pre-transfusion samples were ineffective. The individuals tasked with placing orders for pre-transfusion testing on surgical patients were unfamiliar with the appropriate processes for effectively placing such orders in a timely manner. And the evaluation of the standard surgical blood order schedule revealed significant variations in utilization and questionable effectiveness of the system. As previously mentioned, our analysis revealed that pre-transfusion testing for surgical patients was being ordered via multiple processes. The first process, which is heavily utilized by individuals getting patients all lined up for surgery, was a computer process known as the Surgical Hospital Assignment, or SHA, program. As one goes through the electronic form in SHA to list a patient for surgery, there is a section on transfusion needs, which you will see in the next slide. Individuals filling out this section of SHA mistakenly thought that by filling out this section, they were actually placing orders for testing and blood products. The problem was that SHA simply listed patients for surgery and did not generate any true orders. If nothing else was done other than listing in SHA, then the only way the blood bank could obtain information on pre-transfusion testing and blood product orders was to actively go into SHA and manually transfer that information into the laboratory order system. The second process, known as Orders 97, is a true ordering system that results in messages being transmitted to the appropriate people and the correct actions taken to complete the orders. The third process was a paper system where the personnel at the surgical clinics handed a blood collection card to the patient and instructed the patient to present the card at one of the laboratory service sites. To assess the relative performance of the various methods of ordering pre-transfusion testing, an audit was performed on day of surgery admission patients for the months of June and July 2011. We assessed whether day of surgery patients who required pre-transfusion testing had a sample collected at the very latest 1 day before the scheduled surgery date, and what process or processes were successful and unsuccessful with regard to this goal. What we found was, for patients for whom a sample was not successfully collected at least a day before their scheduled surgery, 85% had no orders placed for such testing in Orders 97. For patients for whom a sample was successfully collected at least a day before their scheduled surgery, 95% had orders placed for such testing in Orders 97. Take-home message: surgical patient pre-transfusion testing needed to be ordered via Orders 97, and we needed to drive the practice in that direction. An analysis of the Standard Surgical Blood Order Schedule, SSBO, at our institution revealed the following details. The SSBO had been developed at least 15 years prior to this particular process analysis. The schedule had been based on the average red blood cell use per procedure, and it had not been updated since 2007. The SSBO contained information for only 122 of the 4,281 procedures listed in SHA. Therefore, the great majority of procedures performed at our facility did not have any sort of designation in the standard surgical blood order schedule. This caused great confusion, wasted time, and sometimes educated guessing when a procedure not listed in the standard surgical blood order schedule had red blood cells ordered in association with it, and the order informs the blood bank to cross-match units as listed in the SSBO. The blood bank employees then had to either track down practitioners caring for the surgical patient in question in order to clarify and agree upon the number of red blood cells to cross-match, or, in the absence of that, guess as to the number of red blood cells to cross-match based on an educated guess of possible red blood cell needs in association with the procedure. Only 42 of the 122 procedures listed in the standard surgical blood order schedule had a specific red blood cell cross-match request. The remainder of the procedures were listed as a type and screen for the order. This slide shows a screenshot of our standard surgical blood order schedule. The procedures are divided by type of procedures, for example, colon and rectal procedures, and beneath the general headers, specific procedures with their corresponding blood bank standing orders are listed, such as TNS for a type and screen, 1 red blood cell, 2 red blood cells, and so on. Here is a table containing information on the percent utilization of red blood cells issued to the surgical services based upon the standard surgical blood order schedule during 2010. The far left column lists the various surgical services. The columns to the right in sequence are total red blood cell units issued based on the standard surgical blood order schedule, the total red blood cell units actually transfused, and the percentage of red blood cell units actually transfused relative to the number of red blood cell units issued. For example, during the time period studied, 13,686 red blood cell units were issued for cardiovascular surgery patients per the guidance of the standard surgical blood order schedule. During that same time period, 6,068 red blood cell units were actually transfused to cardiovascular surgery patients. Therefore, of all the units issued to cardiovascular surgery patients per the standard surgical blood order schedule, only 44.34% of those units were actually transfused. The remainder of the units issued were either wasted because they were out of the blood bank too long, or they were returned to the blood bank for re-entry into the general blood inventory, both of which are costly uses of human and non-human resources. Overall, 20,986 red blood cell units were issued for surgical patients per the guidance of the standard surgical blood order schedule during the time period studied. 11,342 red blood cell units were actually transfused, which amounted to 54.05% of the total number of units issued. Based on our analysis of the standard surgical blood ordering process, we were able to draw some conclusions. First, with regard to cross-matching and issuing red blood cell units for surgical patients based on the standard surgical blood order schedule, transfusion medicine provides approximately twice as many red blood cell units than the actual number of units transfused to patients undergoing these procedures. Because of this, we concluded that the standard surgical blood order schedule was inaccurate, outdated, and essentially obsolete. Therefore, the use of the standard surgical blood order schedule as a guide to cross-match and issuing of red blood cell units for surgical patients should be discontinued. Since our analysis suggested that the standard surgical blood order schedule was no longer a useful tool and that we should consider abandoning it, we anticipated concerns from stakeholders if the SSBO were to go away. We were worried that our stakeholders would express concern about the lack of availability of red blood cells for the first case surgical patients in the operating suites if we did not have cross-matched units ready and available for pickup for those cases first thing in the morning. This table shows data on first case surgical patients between May 16th and May 27th, 2011. Overall, there were 732 first case surgical patients. Blood was requested either via the standard surgical blood order schedule or with a specific cross-match request on 164 or 22% of the total number of patients. 45 of first case surgical patients actually were transfused with red blood cells in the operating room. The total number of red blood cell units transfused to first case surgical patients was 126. The average number of first case surgical patients transfused per day was 4.5. The average number of red blood cells transfused to these patients was 2.8. The average time to set up a red blood cell unit in the blood bank following the receipt of an order was 3 minutes, while the average time from incision to the first red blood cell unit transfused was 1 hour and 23 minutes at one hospital and 3 hours and 1 minute at the other hospital. This data calmed the fears of our stakeholders regarding the discontinuation of the standard surgical blood order schedule. We embarked upon a process redesign of the surgical patient transfusion readiness process in November 2011. The key staff involved were provided education on the redesigned process and the requirements to appropriately follow it. The standard surgical blood order schedule was discontinued. The surgical patient pre-transfusion ordering process was streamlined. The use of the surgical patient blood collection cards was discontinued. The surgical hospital assignment patient listing program was connected to our Orders 97 system, which allowed for orders to actually be placed on patients via this system. All surgical patient transfusion orders were converted to a type and screen. As an institution, we are fully embracing the rapid capabilities of the computer-based electronic red blood cell crossmatch, and, as such, upfront crossmatch orders for surgical patients were no longer deemed necessary. The surgical patient pre-transfusion ordering process redesign facilitates type and screen ordering at the time the patient is seen for surgical consultation. The type and screen order triggers a process where the patient is scheduled for a blood collection through our facility's patient appointment scheduling system. A day of surgery exception process was developed that allows for the identification of patients who require a blood draw for pre-transfusion testing. When this process is initiated, it triggers an automatic page to phlebotomy services with a message that there is a requirement for a blood sample collection when a surgical patient reports to the AM admissions office. With regard to red blood cell orders, the process redesign addressed this issue in the following manner. If pre-transfusion testing of the surgical patient shows no evidence of a clinically significant red cell antibody or antibodies, the anesthesiologist responsible for the case orders the number of red blood cells he or she deems necessary for the case on the day of surgery. If pre-transfusion testing shows the presence of a clinically significant red cell antibody or antibodies, or there is a history of such antibodies, then 2 red cells negative for the corresponding red blood cell antigens are found and cross-matched in anticipation of the anesthesiologist's orders on the day of surgery. Here is a picture version of the linking of the surgical hospital assignment program to our Orders 97 program. This allows us to obtain true and accurate surgical patient pre-transfusion orders from the SHA program. After implementation of the redesign of the surgical patient transfusion readiness process, the next step was to perform an outcomes analysis to judge the degree of success of the initiative. Data from the first quarter of 2011, which was pre-implementation of the redesign, were compared to the first quarter of 2012 after implementation of the redesign. One parameter evaluated was surgical patients requiring a blood sample collection on the day of surgery. There was a 53% reduction in the number of surgical patients requiring to have blood drawn for pre-transfusion testing on the day of surgery. Another parameter evaluated was a valid type and screen documented in our ordering system at least 1 day prior to surgery. In 2011, this was 83%, and in 2012, this was 92%. The project was deemed a success. Additional outcomes analyses were performed comparing data from the first quarters of 2011 and 2013. The total number of red blood cells cross-matched during the first quarter of 2011 was 6,337 red cell units. These cross-matches were performed when the standard surgical blood order schedule was still in operation and practitioners could order red blood cell cross-matches in advance of scheduled surgical procedures via the ordering processes. The total number of red cells cross-matched during the first quarter of 2013 was 3,754 red blood cell units. These cross-matches were performed after the standard surgical blood order schedule had been retired and represent the across-the-board type and screen approach where anesthesiologists order red blood cell cross-matches the same day as scheduled surgical procedures. These numbers represent a 41% reduction in the number of red blood cells cross-matched in 2013 compared with the same time frame in 2011, which we considered a success. The total number of red blood cell units issued to the operating rooms were also compared for the first quarters of 2011 and 2013. 4,143 red blood cell units were issued to the operating rooms during the first quarter of 2011. The units actually issued to the operating rooms accounted for only 65% of the total number of red blood cell units cross-matched for surgical patients during that time period. 3,604 red blood cell units were issued to the operating room during the first quarter of 2013. The units actually issued to the operating room accounted for 96% of the total number of red blood cell units cross-matched for surgical patients during that time period. This improved matching of cross-matched red blood cells to red blood cells actually issued was considered successful performance improvement. We also reviewed data on the number of issued red blood cells that were returned to the blood bank untransfused, which we then needed to return to our blood bank inventory. In the first quarter of 2011, 1,658 red blood cells were returned. This represented 40% of the total number of red blood cell units issued to the operating room during that time period. In the first quarter of 2013, 1,694 red blood cells were returned to the blood bank from the operating rooms. This represented 47% of the total number of red blood cell units issued to the operating rooms during that time period. Therefore, with regard to our performance improvement process, despite clear gains represented by reductions in the number of red blood cell units cross-matched and issued for surgical patients in 2013 compared to 2011, the surgical services still only transfused approximately one-half of the red blood cell units issued to the operating rooms. The surgical patient issue to transfusion ratio continues to be a performance improvement opportunity for our institution. To summarize, completion of pre-transfusion testing for surgical patients scheduled for elective surgical procedures has been a long-term challenge at our institution. Fortunately, thanks to a strong collective effort to work differently, which is undertaken by a multidisciplinary team of key process stakeholders that was sponsored by our institution, the processes of pre-surgical blood sample collection, pre-surgical pre-transfusion testing, and blood ordering for surgical patients were redesigned and standardized. We believe that the efforts of this multidisciplinary team were a success, and we have made elective surgeries safer at our institution. If you like this presentation, please join us in March 2016 in New Orleans for the annual Transfuse Conference. Thank you.